Video. Oops, I'll take the video off. Change the monitor. Yeah. Sure. Okay. It's fine. Fine for me. All right, folks, I'd like to get the second day going. Welcome back. The stats from yesterday are very impressive. We got well attended here and well attended on YouTube. So again, thank you very much for a very exciting program yesterday, and today's program is going to be equally as engaging and exciting. Administrative thing, again, if you've got a parking pass, see Ville or Amber for the to get the parking validation. And with that, I'm going to turn it over to Marcia Griffin, who's going to introduce our wonderful speaker.
David. So yeah, good morning, everyone. Thanks so much for your time. As you will see, the schedule has changed pretty significantly. We've shifted the clinical session all the way to the morning. Andrea Cosarazzi, who has been a significant contributor to FlowTex these last few years, had a family emergency. And so Sarah, who I'm going to introduce to you next, graciously has stepped up to do both his talk and the talk that she had scheduled. So just for a second, I just want to take a moment of silence for him, you know, sending love and light his way, whatever he's dealing with, just out of appreciation. All right, so Sarah DeBasi, I hope I'm saying her name correctly, is an assistant professor of general pathology and immunology at the University of Modena and Reggio Emilia School of Medicine in Italy. Dr. DeBasi obtained the PhD in clinical and experimental medicine in immunology from the same university in 2013. From then, she's been working as a postdoc in the lab of immunology directed by Professor Andrea Cosarazzi. Most of her work was focused on phenotype, function, and the metabolic aspects of adaptive immune response during HIV infection, autoimmune disease, cancer, and these last 2 years, SARS-CoV-2 infection. So get ready. You're going to be hearing some very nice talks. Pass it over to you, Sarah.
Thank you very much. Thank you for the nice introduction. It's a real pleasure to be here with you. Even if I'm in Italy and you are in the US, but of course it is really nice to participate to the FlowTex. So I would like to share the first presentation I will give today. Can you see? Where is it? Okay, so the first presentation, the first topic would be about the single cell approaches for T cells monitoring in cancer. I have nothing to disclose, and this is the overview of the talk. So first of all, I would like to explain to you why it is really important to apply high-dimensional single-cell technologies to the analysis of cancer immunotherapy, why to apply application dimensionality reduction in immunological studies, what to do before dimensionality reduction, so the importance of generating good data, and which is, and I would like to bring to you two different examples on about two different type of cancers, so melanoma and renal single cell and renal cancer carcinoma, treated with anti-PD-1, so immune checkpoint inhibitor. So why it is really important to apply high-dimensional single-cell technologies to the analysis of cancer immunotherapy, because, of course, dealing with the tumor microenvironment, people that deal with tumor microenvironment deal with a lot of different cells and with the highest heterogeneity of tissue. And when you have a piece of tumor, the first thing you have to do is to dissociate this kind of piece into different cells. And after this kind of procedures, you will have to obtain tumor cells, stromal cells, and immune cells. So if you are dealing with tumor cells are able to help in determining the tumor heterogeneity. If you are dealing with stromal cells, they are very useful to characterize tumor microenvironment. And if you deal with immune cells, of course, you can characterize the immune phenotype and the single cell TCR sequencing of the tumor. Of course, dealing with the tumor microenvironment is not always possible, and sometimes we have to deal with peripheral blood that sometimes can be useful because to evaluate how the therapy is going, so to monitor the immunotherapeutic. Peripheral blood is non-invasive, and it is very helpful to perform longitudinal single-cell analysis over the course of the therapy. So this kind of aspects, so to study the tumor cell, the stromal cells, and the immune cells are really useful when you have to deal with, to understand the course of immunotherapy. So you can understand the changes in cell state and heterogeneity. You can understand the expansion or contraction of T cell clones, and you can understand the changes in cell-cell interaction in the tumor microenvironment composition. So this kind of high-dimensional single-cell technology can really help in the prognosis, in the therapy selection, and in the therapeutic monitoring of the immune checkpoint inhibitors. But of course, it's not possible to apply single cell technologies to a lot of, to many patients and to many and different cancers. So usually the general biospecimen framework for incorporating single cell analysis in clinical trial involving immunotherapies are divided into two steps. So the first step is about discovery phase, and in the discovery phase, we can study few patients, we can perform an extensive biospecimens collection, we can study single cell, we can apply the single cell technique and high dimensional analysis. And usually these kind of analyses are technically very challenging. And of course, on the basis of the budget of a research lab you can apply different single cell technologies. And then the second part is the validation phase, so where you can study many patients and where you can translate what you find in the lab to what is really clinical applicable. So lower parameters, easier technique, and not so high high cost, like for example single cell RNA sequencing. And of course, when you are dealing with immunotherapy, so anti-PD-1 therapy, for example, or immune checkpoint inhibitors therapy, you have to deal with immune monitoring of the course of the disease. But of course, you have to take into consideration also the type of the tumors you have to deal with, because of course, dealing with different tumors and different type of tumors, the response can be different. And in this paper, published really recently, they study 21 cancer type, and in particular tumor infiltrating lymphocytes coming from 21 cancer types. And by study this cell by single cell array sequencing and TCR sequencing, the authors were able to identify differential usage of exhaustion path. So for example, they were able to analyze different kind of exhaustion in different type of cancer. So everything should be taken into account, so the therapy, but also the cancers, and of course also the technique used to study this kind of changes. So single cell technologies can reveal the immune system heterogeneity, and the single cell analysis is the study of genomics, transcriptomics, proteomics, and metabolomics at a single cell level. And this kind of analysis is very different from the bulk study of the population, because due to the heterogeneity seen in immune cell population, analyzing a single cell makes it possible to discover new cell population not seen when study a bulk population of cells. And then let me speak about flow cytometry. So imagine to have more than 20 panel, more than 20 color in your flow cytometry panel, and you have high dimensional flow cytometry space and manual gating. So you will have 2 at 20 population and bidimensional plot, and of course a loss of heterogeneity of your discovery population. So why it is really important to apply dimensionality reduction? Because of course, first of all,
excuse me, Sarah, sorry for interrupting. I think we need to check on YouTube. They're saying they can't see it.
You can see?
No, can you just hold on? We needed to fix the link real quick. It's, okay, I don't think it's anything on your end.
Okay.
Just hold for a minute.
Okay.
Go ahead and continue.
Okay, so why it is very important to apply dimensionality reduction, because it simplifies the complexity, so it becomes easier to work with. So you reduce the number of features or markers in your panel. You can remove the redundancies in the data. You can identify the most relevant information, so you can find and filter the noise. It reduces the computational time for downstream procedures. It facilitates clustering, since some algorithms struggle with too many dimensions. And of course, data visualization is really important because it helps you to identify the heterogeneity you have in your samples. And this is just an example of how data visualization can help in analyzing the data, because just by seeing by eyes what you're seeing here, there are 3 different kinds of data visualization. So in the first, on the left, you can see the principal component analysis, and then the t-SNE analysis, and then the UMAP analysis. And just by seeing by your eyes, you can identify different islets and different corresponding to different population of cells belonging to the peripheral blood mononuclear cells. So this kind of unsupervised data analysis really helps in the data analysis. But of course, in order to apply all this kind of technique, you have to produce really good data. So you have to take into consideration the fact that you can introduce batch effect, and you have to deal with batch effect, and you have to remove batch effect. But also, for example, you have to remove the noise and doublets and debris in your panel. And here, for example, the Shapiro-7 law of flow cytometry says that no data analysis technique can make good data out of bad data. And in the FAR 2010, a very seminal paper by Enrico Lugli, Mario Roederer, and Andrea Costarizza talked for the first time about the different methods you can apply, you can use to analyze your data coming from flow cytometry. And they devised the method into supervised and unsupervised. And of course, unsupervised was kind of better because they are operator independent. You can discover unknown population, and principally they are principal component analysis based method. But what you have, but you have to take care about what the data you are producing, and the gating strategy before applying the data. And the unsupervised data analysis should be really clear and really straight, because you have to be sure to remove the noise. So you have to exclude the debris, to discriminate single and doublets. So it is very useful to use forward scatter area versus forward scatter high. You have to pay attention if you are working with, for example, frozen cells or cells that have undergone a stimulation, to exclude the cell death. So it is really highly recommended to use a viability dyes. You can use a dump channel, so you can remove all the lineage you don't want. You have to exclude events during the fluidic issue, and you can do that by different algorithms now available, or you can do that by manual gating. And of course, you have to remove fluorochromes aggregates by using the keeper gates. And in 2016, this is one of the first seminal paper where all the organizing techniques were explained by Ivan Sayes. And here you can find just a quick table whether the most used script are used for the data analysis. So just to stress again how is the importance of advanced cytometry in defining the immune cell types and function. For example, example, in the immunopathogenesis of HIV infection, because by applying, for example, FlowSOM to multi-markers flow cytometry panels help us in identifying cells producing cytokines after in vitro stimulation in different patients with different kind of different course of HIV infection, and of course the different treatment. So the path to the biomarker discovery is very straightforward, and in order to apply this kind of method, to single cell method to your data, you have to follow a very clear and very straight workflow for canonical single cell experiment, where I think that the experimental plan is the most important part, because of course you have to perform the study design, calculate the power of your analysis with statistician and bioinformatics issues, and of course is the part where you enroll patients, so the clinical data are really important for a good prognosis and a good planning. And of course the other part really important is the setup and the data generation, when of course you have to take care of all the setup of the flow cytometry panel as well as the data pre-processing. So the quality control is mandatory. You have to clean your data and you have to check for technical issue. And on the basis of the budget you have and the endpoint of your experiment, I think that nowadays you can really select different single cell technologies on the basis of your pocket and your budget. The flow cytometry is the first single cell technique that can be that were discovered, because it is able to study the single cell expression of single markers in the surface on the cell surface. And you can find a really useful table reported here. So I would like to go into detail. So I would like to bring you what we did in the field of metastatic melanoma patient treated with immune checkpoint inhibitors. So just a little bit of background, just to be aligned. So CD8 T cells can drive adaptive immune responses against several types of human malignancies, in particular those with higher mutational burden and neoantigen load. So this is leading to T cell exhaustion. But among inhibitory receptor programmed cell that one, for example, has been extensively studied and now is targeted by therapies with monoclonal antibodies that are capable to reinvigorate T cell in several cancer settings. And nowadays there are a plethora of studies that are reporting other kind of checkpoints found in different tumors and in different stages of the same tumor. So this one was the first discovered, but of course there are a lot are also in clinical trial. Immune checkpoint inhibitor mediates tumor regression only in a subset of patients, and the mechanism at the basis of therapeutic resistance are poorly known, and several studies have initially focused on the mutational load of the tumor as well as on the quality of the cell infiltrating the tumor microenvironment. So there is a pressing need to understand why some people are able to respond to this kind of therapy and why other people and other patients cannot respond to this therapy on the basis of their tumor microenvironment and, of course, peripheral blood immunonuclear cells. So we were able to enroll 28 patients suffering with metastatic melanoma, and we classify this patient in non-responder and responder, and the clinical characteristics are reported here. What we did is reported in this experimental workflow on PBMC isolated from patient with metastatic melanoma. So we interrogate the patient at 3 different time points, so T0 before therapy, T1 after 1 cycle of therapy, and T2 after 2 cycles of anti-PD-1 therapy. We were able only to work with blood, and so we process to single cell suspension, and we apply a 28-color flow cytometry panel. We perform the manual gating to isolate the CD4 and CD8, so we remove all the debris and we clean all the data, and then we perform phenograph clustering to identify the different clusters. We perform an analysis regarding the frequency of cluster, but also the median fluorescence intensity. In parallel, we wanted also to investigate by single-cell RNA sequencing all the compartment of CD8 T cells. So we performed the analysis of transcriptome by single-cell RNA sequencing. And in the end, we tried to correlate all the data we obtained by flow cytometry and single-cell RNA sequencing with the clinical outcome of the patient to identify, for example, some kind of biomarkers that can, help us in the classification of the patient and to foresee the response to therapy. Here is the gating strategy that we use to identify CD8 positive T cells. So as I told you before, we extensively clear our data by using the time gate, and we selected only the single cell, we selected the living cells, and then we were able to identify CD8 positive T cell and CD4 positive T cells. As I told you before, we apply phenograph to identify different clusters derived from the analysis of these 28 markers, and we were able to identify 28 clusters that, on the basis of the expression of the different markers, we were able to classify them as a terminal differentiated effector memory, exhausted effector memory that express PD-1 or other homing receptor present in the panel, and all central memory T cell and naive T cells. We noticed that before therapy and during the different sampling, so after the first cycle and the second cycle of therapy, the cluster 16, which resemble a proliferating effector memory cluster, was higher in the frequency, was higher in responder patient if compared to not responder patient. This cluster was characterized by a higher expression of CD38 granulizing, CXCR6, CD98, CD71, HLA-DR, 95, ICOS, and Ki67. So proliferating and very activated cell, able also to produce and release granulizing and metabolically active cells. So in order to go more in depth into this kind of population, we sorted CD8 positive T cell from this patient at different time points, and we were able to perform a single-cell RNA sequencing on a total of more than 50,000 cells. And what we were able to do is we identified different population on the CD8 T cells on the basis of the expression of their gene. We were able to identify naive T cells, cytotoxic effector memory T cell, transitional effector memory T cell, memory T cells, two different population of naive T cell, one expressing GATA3 and FOS and the other expressing FOS and JUN, so recently activated T cell, activated effector memory, and the population of mucosal activated invariant T cell. And you can see here that, for example, these kind of, if you can see the pseudotime, this kind of population follow the activation, the expression of different activation markers from the right to the left. And here, for example, you can see that naive T cell, you can find naive T cell here, and then going on with the differentiation, you can find all the rest of the population, but the mite population can be found here in the branch of this T, meaning that this population is kind of different from effector memory T cells. These are the genes that we use to classify the different population of cells. So on the basis of the expression of this marker, we call this cell as naive. This cell was called like cytotoxic because they express granzyme B, granulizing, and other kind of granzyme. And for example, as I told you before, we were able to identify two populations of naive T cell on the basis of the expression of GATA3 and the FOS and JUN. The population of mite cell was was kind of identified by the expression, sorry for that, well, identified by the expression of KLRB1, which is the CD165, by CXCR4, which is a homing receptor, and by MAF, which is really high associated with exhaustion of CD8 T cell population, and in particular on metastatic melanoma patient. Also, to be more sure of our analysis, we questioned the neural network, and we performed a neural network analysis by CPTNet performed to compare gene and protein expression. So we found, given that the relation between gene expression and protein in 0.4, we wanted to be sure that the expression of KLRB1 was really represented by the expression of CD161, which is one of the markers that can recognize mucosal associated invariant T cells. And what we found is that mite cells are more abundant in responders patient as revealed by single cell RNA sequencing. And here we confirm the data we found by flow cytometry. So the activated effector memory T cell were higher in responder in comparison to not responder cell. And not only the percentage was higher before therapy and after 2 cycles of therapy, but also regarding the gene expression profile, responder patient at time 1 and respect to time to this kind of population was really highly activated, identified by the expression of HLA-DR and the FOS, but also more they express higher level of granulizing and granzyme. And moreover, we found that the proportion of mucosal associated invariant T cell was higher in the patient that responds to therapy if compared to not responder 1 before therapy and after 1 cycle of therapy. And regarding the gene expression profile, we see that comparing not responder to responder patient, the population of mite cell of responder patient was really high activated and able to express CXCR4. So we took only the population of mucosal associated invariant T cells, and we reclustered only this population, and we were able to identify 2 different populations of mite cells, so activated mite cell and not activated mite cell. The activated mite cell were characterized by higher level of expression of CD69 and FOS, for example, if compared to those that were not activated. And we were also able to identify at different time points the expression and the percentage of activated and non-activated cell. And as you can see here, the non-responder patient at different time points, the percent of the proportion of mite cells were really low if compared to responder patients. We went through the validation process of our findings performed by single cell RNA sequencing, and we built up a 16 colors panel, flow cytometry panels to identify mite cells. And what we find out is that mite cells were, we confirmed this data, and we confirmed the fact that mite cells, the population of mite cells was really highly represented in responders patient, in particular before starting the therapy if compared to not responder patient, and moreover that the expression of CXCR4 were higher in responders patient if compared to not responder patient, and this kind of expression was increased during the therapy. So after 2 cycles of therapy, mite cells of responder patient was able to express a higher level of CXCR4. So given the fact that CXCR4 is able to drive mucosal associated T cell to enter not only the lymph nodes, but also the metastatic and the primary tumor site, we took a published data set, and we wanted to identify our mite signature in the TIL data set. So as I told you before, we were able to take only peripheral blood mononuclear cell, but this finding should be translated translated into what happened into the tumor microenvironment. So we take advantage of this kind of data set, and we wanted to identify our mite signature in the tumor, and we were able to find mite cells in the tumor. We compare our signature and what it was published, and we see that the Jacquard index was 0.2, indicating that there is a higher overlap between the signature. So mite cells are in the tumor microenvironment. And given the fact that we found that mite cells in the tumor microenvironment, we're also curious to see if in patients that were able to respond or not to therapy, this kind of mucosal-associated invariant T cell was more abundant in responder patient or in not responding patients. So we took advantage of another already published data set, the single cell RNA sequencing data set, and we took only the CD8 and we performed a reclustering of only this kind of population. And as you can see here, the population number 3 was characterized by higher expression of KLRB1, which identify in a unique way mucosal-associated invariant T cells. So we took the proportion of this population into different before therapy and after therapy in responder patient and after patient. And what you can see here is that after therapy in responder patient, there is a higher percentage of mucosal-associated invariant T cells in the tumor microenvironment. So what we found in the peripheral blood could also be translated to what happened in the tumor infiltrating lymphocyte subset. Of course, we wanted also to investigate the polyfunctionality of mucosal-associated invariant T cell after in vitro stimulation, because by now we saw that this kind of population is higher in responding cell, is able to infiltrate the lymph nodes and the tumor the tumor microenvironment, but we don't know what they are doing. So we stimulate in vitro 16 hours with IL-12 and I-18, this kind of population, mimicking what happened physiologically in the blood. And we see that after this kind of stimulation, we were able to identify granzyme production, interferon gamma production, and the TNF production. And in particular, what we find out is that patients responding to therapy were characterized by a higher production of granzyme B together with TNF alpha. And in particular, that before therapy, this kind of mucosal-associated invariant T cell were able to produce higher level of granzyme B if compared to not responder patients. So they were kind of more cytotoxic if compared to the one coming from not responding patient. So we see that the level of mite was able to stratify patient to predict the response to therapy, and in particular patients that have lower level of mucosal-associated invariant T cell, in particular a percentage inferior than 1.7, were the patients that were not responding to therapy, while patients characterized with higher level of mucosal-associated invariant T cell, and in particular with a level that was higher of 1.7, could respond to therapy. So to wrap up this first part of the talk, I can say that patients who respond to immune checkpoint inhibitor are characterized by a different composition of T cell populations compared to those who did not respond. And the most relevant differences was that the level of mucosal-associated invariant T cells was higher in patients who responded to therapy. And of course, we are performing ongoing experiments and tentative to translation to the clinic to study the percentage and the phenotype of this mucosal-associated invariant T cell in order to be considered as a possible predictive marker of successful therapy. Moreover, last but not least, this kind of population, which is a major histocompatibility complex class 1 related molecule restricted T cell belonging to the mucosal associated T cell family, which are defined MR1 T cell, has been described as a rare population able to respond to a variety of tumor cells of different tissue origins, but not to microbial antigens, because mucosal associated invariant T cell can respond to all the microbial peptide presented by MHC, particularly MHC. So this is the first example I brought to you. The second example is about the metastatic renal cell carcinoma patient treated with immune checkpoint inhibitor. Renal cell carcinoma patient accounts for 5 to 3% of all malignancies in men and women, respectively, and almost 15% of these are metastatic disease at diagnosis. So it is really difficult to deal with this patient, but because when they are coming to the hospital, they are already metastatic. This kind of patient, the metastatic renal cancer carcinoma patient, has still a poor prognosis, even if in the last year the life expectancy of this patient really increased thanks to the immune checkpoint inhibitor used alone or in combination, such as anti-PD-1 or anti-CTLA-4 or anti-PD-L1. Only a subset of patients benefit from this treatment, so it is the usual problem. Some kind of patients are going to respond to the therapy and other patients are not responding to therapy. And the reason at the basis of the lack of response are still largely unknown. And plus, I would like to add the fact that dealing with this kind of cancer is very difficult to have pieces coming from the tumor, because of course it is kind of difficult for the pathologists. So there are very few data published about the renal cell carcinoma patient and their TIMI microenvironment, but also there are very few data published on the immunophenotype of peripheral blood mononuclear cell in the renal cell carcinoma. So we apply the same panel we use for the metastatic melanoma patients, and here we apply a new method of analysis which is called FAUST, and I remind you to the publication of this method to understand how it works. But basically this kind of methods is a new interpretation of machine learning for single cell data that can reveal correlates of clinical response to cancer immunotherapy, because this kind of methods is able to is able to identify through a machine learning techniques which kind of markers are more important for the analysis by drawing an annotation forest, and of course it is able to perform an automatic analysis of the positivity and the negativity for the same marker. So at the end, you will have a really extensive matrix of different population which derive from a combination of the positivity and negativity for the different markers. We apply this technique to the 19 patients we were able to recruit with this kind of metastatic tumor and treated with anti-PD-1. I have to say that the treatment was given after previous therapy, which was not successful. The marker used for the clustering was the following. So basically were markers related to differentiation and activation, and we were able to identify 61 clusters among the CD8 population. And among this kind of population, the mainly represented are the terminal differentiated effector memory compartment. Here, for example, was impossible to perform all the color code of these 61 clusters, so we just put all them together just to have an idea of the percentage of the different population in the CD8 cell compartment. And as you can see here, the majority of cells are represented by effector memory, terminally differentiated effector memory T cells, also because, and this could represent also the fact that these patients are aged more than 70 years old. analyzing all the different clusters longitudinally. So before the initiation of the therapy, after the first, the second, and the third time, the third dose of the therapy, we could perform the immune monitoring inside the CD8 population. And what we found is that, for example, a cluster that resembled a population of T cells and memory decreased after the therapy, suggesting that this kind of patient were not able to, and the population of effector memory increased after the therapy, meaning that the patient maybe could not replenish completely the CD8 memory T cell pool. And of course, other cadral experiments are ongoing to explain why this mechanism could happen. So I would like to wrap up the first part of the talk, giving you some kind of future direction. So the application of single-cell technologies has generated and will generate in the upcoming years an explosion of new data with a clear impact on the translational clinical research, thanks to the identification of possible biomarker. And it is likely that a huge amount of information will also totally revolutionize the field of basic research in immunology and cancer biology. So a big effort should be posed to make all data, including the raw ones, available to the scientific community and to create risks for data extraction. And we have, of course, a means to do that, of course, by putting also FCS data in the flow repository and to share the data with all the scientific community. And of course, investigating the role of exhaustion and dysfunction and translating this knowledge to the clinical practice can be considered the main challenges in the battle against cancer and, of course, viral infection. So I would like to finish this first part of the talk by acknowledge, of course, all the people that donate money for research and grants, and all the people who take, who contribute to this kind of work. So in particular, I would like to thank Lara Gibellini, who is my colleague, and also Domenico Lortataro, who take care of most of the computational analysis that I present you today, and I would like to thank you for your attention.
All right, thanks, Sarah. We're going to open for questions on this topic, a very informative discussion around personalized medicine. So any questions from the audience?
Thank you, Sarah. That was fantastic. I'm wondering if you care to comment on the sex differences in your responder versus non-responder.
Thank you for the question. We looked into this because also our reviewers asked us during the publication of the papers, and we performed the analysis also dividing patient by sex, by gender, and we didn't notice any kind of differences in our data set of patients, which is, of course, is very small if compared to other kind of cohort, but in our patient there were no differences in terms of sex.
I'm not seeing any questions online either, but I might be a little bit delayed. But Sarah, really, I mean, lots of people saying, well done here. A very great talk. I think we're all still trying to absorb all the work that you did. Certainly months of time.
Yeah.
So I think with that, yeah, go ahead.
No, I mean, it was a huge work because, of course, also, I mean, this kind of single-cell RNA sequencing experiment was quite huge because technically, I mean, sorting CD8 coming from these people was quite was not so easy because we didn't have a lot of biological material, but at the end, we was able to collect more than 50,000 T cells. So this is a huge amount of single-cell RNA sequencing experiment.
Yeah, I guess we could tie in with one question, tie into yesterday. We talked a lot about panel design and redesign. So when you do find those markers that you need to go after and explore from the RNA-seq, do you end up redesigning a whole panel, or do you have, set panels that, allow you to use drop-in channels for those unique?
No, we check. We focus on mucosal associated invariant T cells because, of course, it was the most important findings of our paper, and we focus the attention on this population, and we built a small panel just to confirm the percentage and the most important markers we were interested in. So, for example, we better identify mucosal associated invariant T cell, which are characterized by the expression of an invariant TCR, which is the invariant TCR 7.2, and also the higher expression of CD161. And moreover, we put in the panel other kind of marker we were interested, for example, from the single cell RNA sequencing data. So, for example, the presence and the expression of CXCR4 in terms of median fluorescence intensity, and also in terms of percentage of population, because when you deal with single cell RNA sequencing, you are dealing with the expression, but also you can compare also the level of expression, and we can do the same in flow cytometry. So we were interested mostly in this kind of aspect. So we did a side panel for the validation of mucosal associated invariant T cell experiments.
Yeah, thanks. Final question from me, if there's not another one, is I did notice, you were using UMAP, really found it quite interesting when you were talking about the mucosal immune cells. Were there other algorithms that you looked into besides UMAP?
Usually we use UMAP, but we also use, we use Phenograph in this paper, but the most used here in our lab is FlowSum, and followed by the data display with UMAP. Yeah, I think it is the one I prefer to represent the data.
Again, thanks for your first talk, and I know it's a lot, so getting ready for a second talk. Do you need a break in between, or are you good?
No, I'm fine.
Okay.
Okay, so I will share the screen again. Here. So, second part of the talk is about COVID-19 immunology and aging of the immune system. During these years, where the people's life all around the world has changed because of coronavirus disease, we learn a lot of aspects of the immune system and the response of the immune system to this kind of viral infection. We learned this from previously coronaviruses such as SARS that provoke SARS and MERS. But what has been most important report is that there is a really huge response coming from both innate immunity and adaptive immunity. And in particular, we have also learned that the cross-reactivity of B and T cells versus other coronaviruses are really important to design, that has to be taken into consideration to design novel vaccine. In this talk, I will briefly discuss the behavior of the immune response to SARS-CoV-2, paying a particular attention to the role of inflammatory phenomena in two particular groups of patients: pregnant women and age subject. Pregnant women, which are characterized by a shift in the Th2 response, for example, until the third trimester of the pregnancy, which are characterized by a Th2 response, and age subjects which are characterized towards a shift of Th1 response, and in particular they are characterized by a low grade, constant grade of inflammation, which is called inflammaging. So we will evaluate the immune response in these two groups of particular patients, so pregnant women and age subjects after SARS-CoV-2 infection. Regarding pregnancy, other kind of coronavirus infection like SARS and MERS have been associated with miscarriage, intrauterine death, fetal growth restriction, and high case fatality rates. And the clinical course of COVID-19 pneumonia in most, but not all, pregnant women has been reported to be similar to that in non-pregnant women. On the other side, we see that the age itself is a prominent risk factor for severe disease because, as I told you before, patients with that are characterized by a age major than 70 years old are characterized by immunosenescence and inflammation. Immunosenescence, which affect the innate immune system, and inflammation, which immunosenescence, which characterize, the T cell compartment, and inflammation, which affect the innate immune response, and in particular the capability of monocytes to respond to create this kind of low grade of inflammation. So during SARS-CoV-2 infection, a status of persistent hyperinflammation followed by an activation and eventual exhaustion have been reported in patients, in normal patients, so in patients not suffering from other kind of disease or not in particular status such as pregnancy or aging. And the mechanism of activation and exhaustion are similarly with that observed not only with other chronic infection, but also during inflammation. So in this kind of slide, in this slide is reported the main changes that happen to the immune system after the SARS-CoV-2 infection, so in response to this kind of infection. So we see that all the compartments are, or the innate and the adaptive immune compartments are hit by this kind of infection, and in particular starting from the innate immunity, we can see that there is a higher level of neutrophil in both forms, so in mild form or in severe form, and higher level of classical monocyte, higher level of cytokine production. And regarding the adaptive immune system, so regarding T cells, for example, we can see in both compartments, CD4 and CD8, so cytotoxic helper and cytotoxic T cell, we can find a higher level of activation marker, higher level of exhaustion markers such as PD1 and CD57, and lower expression of CXCR3 and CCR6, so cells that identify Th17 and Th1 cells. There is an increase of T regulatory cells and also an increase in the plasmablast. Of course, all of these modification that happens to the innate and adaptive immune system can be transferred also in what we call soluble molecules, so the presence of antibody secretion and cytokine and chemokines production. This is also here are reported the cells and the molecules involved in the immune response to SARS-CoV-2, and you can see that, for example, due to the SARS-CoV infection, there is a high release of DAMPs, which is the damage-associated molecular factors that increase inflammation. There is a high stimulation of innate responses, so I'll get that responsible of low antigen presentation. There is a cross-reactivity antibody of different antibodies versus other kind of coronaviruses. There is the lack of interferon production by, for example, the epithelium and the mucosas, and these can induce a lower stimulation of and the capability of antigen presentation by dendritic cell. There is a massive recruitment and activation of granulocytes, also because the higher production of IL-17 by Th17, and also there is a massive production of pro-inflammatory molecules. So all this is caused by the SARS-CoV-2 infection, and we were one of the first group that were shown by flow with flow cytometry the activation effect of this kind of infection. So an increase of HLA-DR/CD38 in a different populations such as CD4 and the CD8, and also we were able also to identify other kind of changes such as an increase increase of naive Treg in COVID patient, an increase in effector memory cells expressing PD-1, and also a central memory compartment expressing the HLA-DR, CD38, and PD-1 in COVID patient if compared to control. We were able to show this among CD4 T cell population, but we were also able to show this among CD8 T cell population, and in particular here also in the T cell population we were also able to identify terminal differentiated effector memory expressing CD57. So an immune system which is characterized, which is kind of similar to that you can find in aged people. From cytokine production, after in vitro stimulation, we were able to show that CD8 positive T cell coming from patients with COVID-19 infection were able to produce more in IL-17, and also from CD4 compartment and also from CD8 compartment. And this could be really significant because IL-17 is the cytokine that is able to recruit neutrophils in the inflamed tissue. We were also able to display what happened in the B cell compartment, also always by flow cytometry. We were able to identify different subset of B cells, such as memory switch B cell, naive T cell, transitional B cell, memory unswitch, memory IgM only, and also the population of plasmablasts that express or not IgM. Moreover, we were also able to identify a population of unswitched B cell that express CD24, which could resemble a population of exhausted B cells. And what we were able to point out is that the COVID patients were characterized by a really high level of circulating plasmablast if compared to control, but also the other proportion of cells were completely flipped if compared to those of control. We were able also to investigate the monocyte compartments, and in particular we did that by flow cytometry, but also we were able to study also the metabolic aspect of a monocyte, because as you may know, the metabolic aspect is really strictly connected to the function of the cells. So we were able to identify by flow cytometry the different population of monocytes, such as classical monocyte, intermediate monocyte expressing or not the CCR2, and the non-classical monocyte. What we find out is that the classical population was lower in patients with COVID suffering from COVID-19 if compared to healthy subject, and there is an increase of non-classical population if compared to a healthy subject. Moreover, we noticed that the exhaustion markers such as PD-1 and PD-L1 was higher in all the subpopulation of monocytes. And from a functional point of view, they were, this kind of monocyte were able to produce the same amount on interferon gamma, TNF-alpha, and interferon gamma and the TNF-alpha. But looking at the metabolic aspect of monocyte, we were able to show that the monocytes show an altered mitochondrial functionality. So we isolated monocytes and we investigated the metabolic aspect of monocyte by investigating the mitochondrial mass and the mitochondrial membrane potential by flow cytometry and also by microscopy. And as you can see here, you can see that staining monocytes with the mitochondrial green that stain mitochondria independence from the mitochondrial membrane potential, you can see that the COVID patient was characterized by a higher stain of mitochondrial green, indicating a higher, bigger mitochondria, and also that patient suffering from COVID-19 patient were characterized by a higher percentage of depolarized mitochondria. We wanted to confirm this data by looking at the mitochondria by microscopy. And as you can see here, you can see that the mitochondria shape and the mitochondrial size was different between a healthy subject and COVID-19 patient. And in particular, looking at this infrastructure, you can see that the mitochondria of COVID-19 patient was kind of altered, and they were characterized by mitochondrial swelling of the crystal. We wanted also to confirm the metabolic aspect by investigating the oxygen consumption rate and also the extracellular glycolytic cellular acidification rate. And we measure all the aspects related to the metabolic features in a COVID-19 patient and also in healthy subject. And we were able to identify differences regarding the basal oxygen consumption rate, but also regarding the proton leak and the spare respiratory capacity, and also in the basal extracellular acidification rate. So this kind of cells, this kind of monocytes coming from COVID-19 patient were highly glycolytic if was really exhausted, metabolically exhausted compared to the healthy subject. Talking about innate immunity, we talk about monocyte, but we have to talk only on neutrophils, because it has been published thanks to a really huge site of panel that neutrophils in COVID-19 disease is kind of an heterogeneous population, and in particular there is a characterization, identification of immature neutrophils, circulating immature neutrophils that are really quite new because they have not been extensively characterized from a functional point of view and also from a marker expression point of view. In this paper, they identify 8 clusters of neutrophils going from the pro-neutrophil going through the mature neutrophil. And neutrophils are really important because in the inflammation, not only because they are the first player that arrive in the site of inflammation in the case of inflammation, and in particular in the case of COVID-19 SARS-CoV-2 infection, but also because they are able to produce a plethora of pro-inflammatory cytokines and chemokines, and also they are able to form the extracellular, the neutrophil extracellular traps that can drive several severe pathologies. And neutrophils is really an important population because they are they can be a target of different inhibitors that can stop the neutrophils to function, and they can stop to induce inflammation. We perform our study also in the neutrophil compartments of COVID-19 patients, and also here we found that comparing for example, the glycogen reserve inside the neutrophils, the COVID-19 patients were characterized by higher level of glycogen, and this kind of higher level of glycogen can drive the formation of extracellular traps. Analyzing also the innate immunity, we have to analyze also the capability to produce different cytokines. And so analyzing this kind of soluble molecules that are able to induce these cytokine storms. We were able to analyze more than 62 soluble molecules in our cohort of patients. And what we can see from this slide is that the immune system of SARS-CoV-2 patient is able to drive inflammation by producing a really high amount of pro-inflammatory cytokines, but also to induce a higher production of anti-inflammatory cytokines, meaning that the immune system is kind of trying to orchestrate the immune response, but in a very disorganized way. But what is the milestone of this cytokine storm in COVID-19 patient is the higher level of IL-6 that characterize the first step of infection. And blocking interleukin-6 can save the COVID-19 patient, because of course there are different drugs that can block IL-6, and for example in our cohort of patients we use tocilizumab to block and to block the production of block the function of IL-6. And in our cohort of patients we proved that when there were any kind of approved therapy, the use of tocilizumab were able to diminish the probability of mechanical ventilation of that if compared to healthy, to the control patients. So summarizing the immunopathology of COVID-19, you can see that all the aspects, all the immune compartments are affected by this kind of infection, and in particular there is the immunopathology of COVID-19 is characterized by lymphopenia, which affect the T cell compartment and K compartment and B cells, by higher level of activation, lymphocyte dysfunction, increased production of antibodies, and abnormalities of granulocytes and monocytes, together with an increased production of all cytokines, so pro-inflammatory and anti-inflammatory cytokines. So what we know about the infection and pregnancy. So during pregnancy, the immune system undergoes relevant changes, which are different on the basis of the trimester of the pregnancy. And this kind of immunological shift that is towards Th2 in the second part of the trimester is basically driven by hormonal level. And the immune system of pregnant women is characterized by anti-inflammatory immune tolerance, immunological tolerance, and for this reason, many autoimmune diseases go into remission during this phase, only to flare again in an early postpartum period. It is known that coronaviruses can have a strong impact on pregnancy, and different questions still need to be answered, such as why symptoms and severity of SARS-CoV-2 infection seems different in most, but not all pregnant women, how the infection can cause complication during pregnancy, or which is the frequency, if any, or vertical transmission. What about what we know about aging? So as I told you before, aging of the immune system is characterized by two aspects. So immune senescence, which affect the adaptive immune response, and inflammation, which affect the innate immune response. And of course, due to several well-known phenomena like TMT involution, expansion of megaclones directed toward other viruses such as CMV or ABV, changes in T and B cell functionality, increased production of pro-inflammatory cytokines, and other kind of changes can really affect the immune system, the functionality of the immune system of all individuals, and the immune system of this all individual is less capable to cope with a number of antigenic stimuli of different origin. So different questions need to be answered, such as why symptoms and severity of COVID-19 are markedly higher in age subject, and which are the mechanisms beyond this kind of complication and the high rate of mortality. So first of all, I would like to present you the data we published on pregnant women. We were able to measure the plasma level of 62 molecule. We apply a 38 parameter mass cytometry to investigate the peripheral blood mononuclear cell landscape of pregnant women affected with the SARS-CoV-2 and the infection, and pregnant women negative for the infection, so healthy, our healthy controls. And of course, we were able also to measure the T cell production of cytokines after in vitro stimulation, together with the capability of the capability of these cells to proliferate. So this is our cohort of patients, or our patients were paucisymptomatic or asymptomatic patients. The median age was 33 years old, and the patients were matched for age with 28 pregnant women negative to nasopharyngeal swab. and 15 non-pregnant healthy women, median age of 39 years old. So first of all, we analyzed through the 38 parameter mass cytometry puzzle the landscape, the PBNC landscape. And here you can see represented all the population we found in the PBNC landscape of pregnant women. We were able to identify different population of central memory, so spanning from naive to effector memory population expressing CD57, also different population of CD8 T cells, naive B cells, memory B cells, different population of monocytes, so classical monocytes, intermediate monocyte, non-classical monocyte, and also different population of NK, which are really important during the pregnancy, such as early NK, mature NK, expressing or not the senescent marker CD57, gamma delta T cell, plasmacytoid dendritic cell progenitors, mucosa-associated invariant T cell, and also a population of low-density neutrophils that were characterized like that for the expression of, as you can see here, CD60B and the expression of CD11B and the expression of CD16. We didn't find any relevant differences in all the landscape, the PBNC landscape between negative pregnant women and positive pregnant women. The only differences we found is the population of low density neutrophil, which was higher in pregnant women with the subsequent infection if compared to negative pregnant women. Regarding the expression, we were able also to characterize more in depth the T cell compartment by analyzing the expression of different chemokine receptor and different markers connected to the functionality and the switch Th1 and Th2 cells of the cell in T cell in pregnant women. So we were able to identify Th1 shift cells on the basis of the expression of CXCR3 positive and Tbat positive T cells, or Th2 on the basis of the expression of the CCR4 and GATA3, and the Th17 on the basis of the expression of CD161 and CCR7. We characterized by marker expression. We didn't find any relevant differences in all the group we studied among CD4 and among CD8. Of course, the percentage were different because CD4 mainly was represented by Th1 and Th2, and the main population in CD8 was represented by Th1. We were also able to characterize T cells, the 40 cell, from capability of proliferation in the three groups of women. So we stimulate in vitro T cell by CFC dilution. We were able also to calculate the proliferation index and the division index. And what we found is that pregnant women, negative and positive, were characterized by the same capability of proliferating. We also were able to calculate, evaluate the cytokine production after in vitro stimulation, of course, taking into consideration IL-4 production, and so Th1 and Th2 cytokines. And what we find out is that pregnant women were characterized by the same level of production of different cytokines among CD4 and also among CD8. Taking into consideration also the plasma levels, so the 62 plasma level molecules, we were able to analyze, dividing the cytokine production in pro-inflammatory and anti-inflammatory. We see that if you look at the last column of the table, you can see that the comparison between pregnant negative and pregnant positive, we can see that pregnant positive patients were characterized by higher level of anti-inflammatory molecules such as IL-1RA, IL-10, and IL-19, meaning that this kind of group of patients, so pregnant positive patients, were able to endogenous control the inflammation caused by SARS-CoV-2 infection. And moreover, taking into consideration the level of cytokines and the level of low-density neutrophil, we found that there were some kind of positive correlation only in positive pregnant women. So this kind of correlation is still under investigation, because of course we would like to understand why this kind of low-density neutrophil positive correlate with all these kind of cytokines, and which is the functional aspect of this low-density neutrophil. The last part of the talk is the focus on the molecular and cellular immune features of aged patients with severe COVID-19 pneumonia. This is a recently new paper. It is still under revision, but you can find it in Research Square, and I report here the DOI for all of you. So SARS-CoV-2 in the context of aging process, as I told you before, people with aged people are characterized by immunosenescence and inflammation, and we wanted to see the effect of SARS-CoV-2 infection in the aging, in the immune system of these aged people. So we study a total of 35 COVID patients under 60 years old and 26 COVID patients over 70 years old, among which 15 died during the infection. And we wanted to compare all these data we obtained with the healthy donor. These are the clinical characteristics, the demographic and clinical characteristics of COVID-19 patients, and you can see here that they are different from sex. They are most of them are male, in particular in the COVID over patient. They were characterized by different level of chronic kidney disease and different level of creatinine, and which is really high correlated with the age of patients. First of all, we wanted to characterize the cytokine storm in aged COVID-19 patient. We were able to measure the same number of soluble molecules, and you can see here all the difference we found in the plasma level in the cytokine plasma level of age under 60 years old and over 70 years old. And again, we see that even if this kind of population, even if this kind of group, so the group of over 70 is characterized by inflammaging, you can see that it is characterized also by higher level of IL-6 production also during SARS-CoV-2 infection, but lower level of interferon gamma, for example, lower level of interleukin-2, so a kind of exhaustion and a kind of low-grade inflammation. After that, we wanted to study the PBNC landscape. So also here we applied a 38 markers panel, a mass cytometry panel, to identify the different population. And as happened before, we were able to identify different populations spanning from CD4 naive T cell up to the cells of the innate immunity, such as monocytes and monocytes, NK, and plasmacytoid dendritic cell expressing or not CXCR3. We compare all the proportion of this cluster within, among healthy donors under and over group, and we found that, for example, the central memory compartment of CD4 T cell was lower in over patient if compared to under patients that were aged less than 60 years old. So we focus our attention on this population because we wanted to investigate why, for example, this population that give rise to the population of effector memory T cells is lower in over if compared to under. Before doing that, we cluster also all what we found by using PCA, and you can see here that on the basis of the immunological parameters found by the flow cytometry panel, we were able to clusterize the three different categories of patients into three different groups that clusterize in a spatially different area of the PCR. And if you have a look at the contribution of the variables to the PCA, you can see that mature NK, plasmacytoid reticulin cell, B memory cell, and also CD4 central memory T cell are really highly contribute to divide this category of patients into different area of the graph. We were also able to investigate the proliferation index and the percentage of cycling cell in COVID-19 patient and healthy donor, and we find out that T cells and B cells coming from over patient were characterized by a lower proliferative index, and if compared to under patient. As I told you before, we focus our attention on the central memory compartment of CD4 T cell, and we sorted this population, and we perform RNA sequencing to investigate the differential level of expression gene between patients with different age. And what we find out is that T cells, CD4 central memory T cells coming from patients that were age major than 70 years old were characterized by higher level of expression of genes that were related to exhaustion, such as, for example, CTLA4, DUS4, LAG3, and CCR5, together with the chemokine receptor CXCR3. We wanted to confirm also this by flow cytometry, and in our flow cytometry panel, we had the possibility to investigate the level of expression of PD-1, and as you can see here, the level of expression of PD-1 was higher in patient age more than 70 if compared to those younger patients. So again, we wanted to focus our attention on the CD4 cluster to have more insight, a wider resolution on the different subpopulation of all the T cells, and we were able also to identify by doing these different subpopulation of central memory T cells, such as activated central memory T cell that was characterized by Th2 chemokine receptor expression or PD-1, and also circulating follicular helper T cell, which is a particular cluster of central memory T cell. And we noticed that this population, the population of circulating follicular helper T cells were lower in comparison to what was lower in over patient if compared to under patient. This kind of data was really important to us because we saw an inverse correlation between the percentage of plasmablast and the percentage of circulating follicular helper memory T cell, meaning that there is a kind of compensatory mechanism in this patient to mount an immune response able to contrast the SARS-CoV-2 infection. Taking into advantage the fact that other groups publish single-cell RNA sequencing data of antigen-specific CD4 T cell, we took that data and we selected the patient, the older patient and the younger patient, and we in order to analyze the antigen-specific compartment. And what we found is that we were able to identify 5 different populations in the antigen-specific compartment. One is cycling cell, and also again we were able to identify this kind of follicular helper T cell, which is the population 1, which was again equally represented in COVID patient, in under patient and over patient, meaning that if from a circulating point of view, so taking into consideration all the PBNC, the percentage was different, but those antigen specific was equally represented. Given the fact that we found a lot of differences in the chemokine and the cytokines that involves the migration of the monocytes from the peripheral blood to the inside, to the inflamed tissue, we pose our attention on the monocytes, and we took the CD14 positive population, and we performed the clustering of this population. The clustering of this population allows us to identify different subsets of monocyte besides classical monocyte, intermediate monocyte, and non-classical monocyte. For example, we see that in a particular cluster in patients with age more than 70 were characterized by high level of immature monocytes and higher level of monocyte expressing CD56, which is a population of monocytes that is more prone to produce inflammatory cytokines in the case of need. And here you can see all the differences in the monocytes compartment, and you can see that immature monocyte was higher in COVID over patients, so in a patient age more than 70, meaning that the immune system is trying to cope with the infection and releasing higher amount of immature monocyte, also due to the higher level of monocyte colony stimulating factor we found in the peripheral plasma. Monocytes are able to migrate into the inflamed tissue, and also thanks to the higher level of cytokines we found. And so, taking into advantage of already published paper by Rendero et al. On Nature 2025 dealing with imaging mass cytometry, we took advantage of this cohort of patients. We selected patients who were interested in, so patients with COVID with lower than 60 years, and those with major than 70 years. And we analyze the data coming from this kind of data set, in particular focusing our attention on macrophages, which are the tissue resident compartment of monocytes. And we found that even if the number of macrophages identified by the expression of CD68 was the same, was not different between the Kuhn and COV patient, we found that the macrophages of COV patients were characterized by high colocalization of mimetin and collagen type 1, meaning that these kind of cells are able to contribute to increase the collagen deposition, and so contributing to the to the fibrosis that happened in SARS-CoV-2 infection. And in particular, the spatial colocalization of activated macrophage expressing simultaneously CD68, vimentin, and apoptotic size, we were able to show that this kind of macrophages was able to induce cell death to the cell expressing cytokeratin, keratin 8 and keratin 18, so epithelial cells. So I just want to conclude this kind of the second part of the talk, that the immune response is crucial to protect from all infection, including SARS-CoV-2, and indeed most individuals do not develop symptoms. Unfortunately, in some cases, the excessive immune response creates serious damages to several tissues and organs, and some of the mechanisms and cells responsible for this phenomenon have been represented in this lecture that underlines the importance of controlling inflammation. So I show this with taking into consideration the pregnant women, but also the age patients. And of course, given the fact that we learn that the immunopathogenic mechanism which through which the virus act, we have a possibility to develop effective therapeutic strategies capable of hitting multiple targets. And of course, just to mention the fact that the vaccine developed with different technologies are now saving countless lives over the world, and vaccine must be available for free everywhere for all human beings, not only for those living in rich countries. And having said that, I would like to acknowledge all the people that contribute to the realization of these huge studies we were able to publish in the last 2 years. So I would like to thank all the clinicians working to the infectious disease clinics, to the Department of Anesthesia and Intensive Care, Respiratory Disease Unit, Department of Laboratory Medicine and Pathology, the Division of Molecular Oncology and Immunology, and also Fluid Island Corporation, with whom we have a very strong collaboration ongoing. And of course, I would like to thank all the people working in the lab and that contributes in these 2 years to produce the data I have shown you today. And I would like to thank you for your attention.
Dr. DeBasi, just excellent job again. We're going to open up for questions. I think incredibly informative.
Sarah, thank you so much for your talks and for all the work you guys have done in understanding the immune response to COVID. It's been great to see the whole journey. Quick question about the reclustering you do, and it's more a technical question. When you go deeper on that population, the central memory CD4s, and you do the reclustering, you go for certain markers to do that recluster, thinking that the big ones that are highly expressed might be masking the tiny populations you want to undercover.
Yeah, this is the reason why we are doing reclustering, because when you are doing this kind of cluster, when you are applying this kind of clustering methods to a panel which have markers spanning from T cells to monocytes and other kind of population, tiny differences cannot be detected. That's why we usually focus on, first of all, we perform the first analysis, taking into consideration all markers to define the total landscape, and then we take into consideration only a particular population. So in the case of CD4 and in the central memory, population, we took into consideration the total CD4, because taking into consideration the total CD4 was sufficient and enough to identify different marker expression and the median fluorescent intensity expression inside this population. So when we had to sort, we sort, of course, central memory CD4 T cell, but when we have to analyze and clusterize CD4, we focus our attention on the total of the CD4 population. And then in this population, we could see the difference of population of CD4, among which central memory T cells and, for example, circulating follicular helper memory T cells.
And the cluster is on excluding lineage markers?
The clustering is done, within the CD4, so we exclude all the lineage marker, we perform this kind of reclustering. So the 100% of our population is the CD4. Inside this, we can do the reclustering.
Thank you so much.
Thank you to you.
We have a couple questions online. The first one is, can you see if the follicular helper T cells in circulation are functional?
No, this would be this is a nice question, because of course we only notice that these kind of cells inversely correlate with the percentage of plasmablast, but we didn't have a chance to investigate the functionality of this cell. But that's a great question. I mean, that's what we need to conclude this kind of assumption that the immune system is kind of balance the immune response by increasing the level of plasmablast. This is a great question, but unfortunately I don't have the answer, because we didn't do this kind of experiment.
Okay, there's another one online. Can you comment on the challenges of including criteria for the aging patients, such as days after COVID infection, treatment, corticosteroids, and others?
Thank you very much for this question, because it allows me to say what I didn't said before, that our patient and our sampling was in the acute phase. So at the admission of the infectious disease clinic or ICU. So they were, I mean, all the patients were the same for the time of, more or less comparable for the time of days of infection. Regarding comorbidities, yes, we had kind of trouble because we had to exclude, of course, patients with comorbidities such as, for example, obesity or other kind of disease that had an impact on the basal inflammation and the basal level of inflammatory aspect. Yes, but this was really difficult to perform because, of course, when you are aged more than 70, I mean, I mean, it's normal to have kind of pathologies such as cardiovascular diseases or other kind of disease. So I mean, we try to be as much stringent as we could by comparing the same days of infection and more or less the same comorbidities. But of course, we excluded people with cancer and people with obesity.
Thank you very much, Sarah.
Thank you very much to all of you.
Right, so I think we'll take a break now. Yeah, and we'll be back, what time? 11? So it'll be a longer break. You have about 30 minutes. Thanks, everyone.
All right, let's go ahead and get started. It gives me great pleasure to introduce Dr. Diana Bonilla Escobar. Known you for many, many years. She's an immunologist with a PhD from Texas A&M University and a postdoc through Baylor Medicine. Is ASCP certified and has more than 20 years experience as a biomedical scientist in a variety of applications, including infectious diseases and cancer at MD Anderson Cancer Center. She's one of the ISAC and SRL emerging leaders and is highly involved with ISAC educational opportunities and task forces, and she currently works as the U.S. application lead for Cytec Biosciences. So please welcome Diana.
Well, good morning, everyone. Thank you, David, for the introduction, the organizing committee for the invitation, Karen. It's a pleasure for me to be here again. Last time I had an in-person meeting was FlowTex 2020, so happy to be back in the spaces where we can talk about flow cytometry. Briefly, what I'll be telling you guys is how useful particular technology, full spectrum profiling, is to understand autofluorescence from your unstained cells and how that can be useful after extraction to get better resolution at the data. Two main players for the talk. There you go. Autofluorescence, then the technology, full spectrum profiling, how we can use it for characterization of autofluorescence and also for extraction. And most of the time, I'm going to spend it talking about a case study. It's a very highly fluorescent or autofluorescent tissue in your skeletal muscle. So kind of the perfect scenario where you will see a lot of complexity in terms of autofluorescence and how the software, the technology can help you get better resolution. Briefly, autofluorescence, right? This is that intrinsic emission of light you get out of the cells when you just run unstained cells on a cytometer and you get light out of that excitation. So quick example, and this is microscopy, different cell types, how different the autofluorescence after UV excitation can be in terms of intensity, in terms of the localization, and as we will see here in terms of the wavelength at which that light is being emitted. There are also changes not only in terms of cell size, in how granular their cells are, but also in terms of their metabolic state. So if we compare, for example, leukemic cells and normal cells, leukemic had this homogeneous distribution of the fluorescence, autofluorescence, because of the changes in metabolism that they have, and also changes in experimental conditions. So if we see untreated cells treated with a chemo toxic agent, what we see is again, not only the amount of light that you get, the distribution of that light, but also the wavelength from 450 to 600 nanometers whenever the treatment is added. And we know that autofluorescence comes from different biological structures within the cell. So we have things like collagen, elastin, the organelles, like lysosomes, mitochondria, and different metabolites that can be fluorescent. And we can detect that light on the cytometers. So this is a brief list of things that within the cells that can emit light. Most of the excitation comes out of the UV and violet lasers, and the emission goes all over the place, right? From UV, violet, yellow, green, and red. And the type of component is going to depend on the type of cell you have. So for example, eosinophils are highly known to have a lot of levels of flavins. So you will see yellow, green, and red emission out of the unstained cells. An important consideration for when we design an experiment and also a panel is knowing that autofluorescence is very dynamic. So it changes just with physiological processes, like when cells are growing, when they are proliferating, depending on their nutrient availability, and when they're producing energy. Also under pathological conditions, stress, hypoxia, diseases like cancer, treatments like cytotoxic agents, and also conditions within the experiment that can change the amount of autofluorescence that we get. Things like fixatives, hybridization buffers, and definitely stimulation changes, general increase in the amount of autofluorescence we get. But in general, big conclusion would be that larger cells that are more granular, cells that are stressed, that are dying, and cells with higher content or activity in their lysosomes and mitochondria are going to have higher autofluorescence. And in general, what we used to do years ago was to just work around autofluorescence, right? Either using a quencher to remove unwanted autofluorescence, or changing the staining protocol in order to reduce the amount that we were getting, like reducing the fixative, for example, or just using red dyes that are emitting in an area where autofluorescence is not causing high background. And just quick example from microscopy, we are seeing here red blood cells. They can generate a false positive compared to the real fluorescent signal. But if they are quenched, if the signal coming from red blood cells is quenched, we can then get a better identification of what's real positive. And other options, we could computationally remove or extract the autofluorescence. And there's a great example. We have a HeLa cell that expresses GFP, and we see the background, the autofluorescence. So being able to remove that in order to see, once again, the real fluorescence, it's very critical in order to get better signal to noise ratio. The other option is, depending on your experimental system, the amount of autofluorescence you get could be useful to characterize the system without any exogenous dye. And that's what we call the label-free cytometry or naked cytometry. That has been very useful in plants, cyanobacteria, because of the pigments that they can have that had certain emission profile, like plants, chlorophyll, that we know had red emission and can be excited by the UV, the violet, and the blue laser as well. So now if we talk about full spectrum profiling and how useful it can be to understand autofluorescence, it can help you extract it, or it can help you take advantage of it. So the next few slides are telling you, we have seen, well, we saw yesterday, multiple talks about spectral cytometry. So I know a lot of you are already familiar with full spectrum profiling, at least the Cytec instrumentation. But briefly, for the people that don't know about full spectrum, brief introduction. If you're used to conventional cytometer or cytometry, you know that if you want to detect FSPTM, what you need is a bandpass filter that allows you to capture the peak of emission. Let's say FSPTM peak of emission is going to be 530. So your bandpass will go from 510 to 540. And that's the amount of light you will get out of FSPTM. And all the other photons below 510 or in between 510 and any secondary detector for another fluorochrome will be ignored. And that's conventional. So if I now move to how full spectrum profiling works, what we have is multiple detectors. And this is after you excite the cells with the blue laser. So multiple detectors collecting the light that it's emitted from the shorter wavelengths, around 480 to up to 830 nanometers. And then the key point is to capture the full emission profile, right? All the photons that FSPTM it's emitting, not only after being excited by the blue laser, but including all the lasers, depending on the configuration you have. So if we talk, for example, about a 5-laser system, what you get is that characterization out of the blue module, or blue multiple detectors out of the blue module. And for detectors, we use APDs, avalanche photodiodes. But since we have 5 lasers, we're going to have multiple detectors to take a look at the full emission profile. And if you have that 5-laser instrument, you have 64 detectors total. And what we get out of each sample, each fluorochrome, including each unstained sample, it's the full characterization. So you go and get this, which are called the spectral signatures. Spectral signatures show you that what happens after exciting a cell with the UV laser, violet, blue, yellow, green, and red, how much light or the intensity of the signal in the y-axis you're getting, and across all the detectors in the system. So if I'm characterizing this fluorochrome, which is brilliant violet 750, what I'm clearly seeing is that most of the emission, the highest intensity, it's out of violet 14 expected for that fluor. And just quickly, because we're going to be seeing a lot of these signatures, each of these boxes is showing me a histogram, or the distribution of the intensity within a certain population, where red indicates the peak of that histogram, and green and blue areas with less density of events. So I have the full idea of what's the excitation emission pattern, and briefly to compare this is what we have with full spectrum, and by conventional, you have only the peak. So that gives us an advantage, right? And it's, if I run an unstained sample, these are unstained lymphocytes, I get an idea of what's their signature and how it's changing across treatments, how it's changing across staining protocols, and how much light we are getting that could be impacting the resolution of your markers. And to kind of relate this to what I said before. So a lot of cellular biological components that are going to be emitting at certain wavelengths, excited by certain lasers. And this is the classical profile we get out of lymphocytes, emission in the UV, in the violet, and stained lymphocytes, and a little bit on the early detectors out of the blue laser. And as you see, not much out of yellow, green, and red. That's where we get most of the emission from eosinophils, from alveolar macrophages, from red pulp macrophages, and in general, activated macrophages. So things are going to change a lot depending on how your sample looks, what populations are present, how similar those populations are in terms of autofluorescence. Some of the samples are going to be very homogeneous and easy to characterize and extract the autofluorescence. Things like cell lines, purified populations, and even if you go on a complex sample out of the scatter profile, forward scatter, side scatter, this is whole blood. But if I care only about the lymphocytes with low scatter complexity, then that's a simple scenario that can be quickly, in which the autofluorescence can be quickly assessed and extracted. Again, similar to what I showed you before, right? This is just lymphocytes, emission out of the UV, violet, and blue detectors. And a clear observation from here, it's that the tightness of those rainbow boxes that we have out of each detector, the CVs are really low, and that indicates it's a homogeneous population. But we are going to move in complexity, right? If instead of analyzing just the lymphocytes, I want to check monocytes and granulocytes as well. So my gate out of the scatter plot is a little bit wider. What I'm seeing on the spectral signature is more heterogeneity. Now the pattern of emission, which is the spectrum, the ups and downs in that signature, might be the same, might be different. But what we are also seeing is that if I take a look at just one detector, violet 7, the spread of the data in terms of intensity, it's higher, or is clearly heterogeneous population. So it is so important with every experiment that we ran just to go with the unstained sample, because that's going to give you an idea how complex the sample is, and also give you an idea for panel design, how critical it is to understand things just on the unstained to learn about autofluorescence. And to give you 2 more examples, now very heterogeneous samples. This is a mouse lung. You see, just from the side scatter, forward scatter plot, I cannot tell where the different subsets are. And from the scatter or spectral signature, I'm seeing that there is not a clean profile. There are multiple things in there, some of them with low emission out of the UV, high emission out of the UV 13, 15, a lot of variation. And if we focus only on one detector, UV8, we see that some cells have low emission, some others have high emissions, indicating that multiple populations are there, multiple populations that are very different. And if you want to extract that, you need to take that into consideration to do specific extraction. So knowing how we characterize it, right? Using those spectral signatures, knowing the pattern, knowing how many populations are there. Then that light that it's being emitted by unstained cells could be extracted from your data in the multicolor sample in order to get better resolution. And we do that by using SpectroFlow software. And if you come from the conventional background, conventional cytometry background, you are used to compensation, where if you have a multicolor sample with multiple fluorochromes in there, you bring single stain cells or beads to understand what fluors are present. In spectral cytometry, we use unmixing. Similar principle, it's an algorithm that will allow me to see in a multicolor sample with multiple fluors, what's the composition of different dyes in there. And we use the same single stain controls that we call reference controls. And definitely we need an unstained sample to know the basal level of emission. So let's say you run a multicolor sample. This is what you will see, multiple fluors in there. And the way to understand which ones are present, it's running single color controls. Each one of them will have a specific signature, and then we'll be able to decompose in the multicolor sample the different things that are there. But a critical step is the autofluorescence. Because from all those photons in the multicolor sample, we want to know which ones are just coming from the ants, from the intrinsic emission of light in the cells, and then be able to assign all the other fluorescent, all the other photons to all the different fluorochromes present in the sample. So within the software, you have two options. You can either do that and mixing, default and mixing, or you can, and that's one checkbox that you click on, or you can do autofluorescence extraction. When we do autofluorescence extraction, what you have is, we know what autofluorescence looks, right? It's just the pattern out of unstained cells. That could be included as one more fluorochrome in your panel or in your experiment, and it's going to be treated as any other fluorochrome, and that's the way we can extract. But briefly, what's going behind scenes in the software? As I mentioned before, you have a multicolor sample emitting multiple photons when it's run through the cytometer. First thing is to understand from those photons which ones are just the intrinsic emission, the autofluorescence. So we subtract that intensity. And then we build the unmixing metrics by using the single color controls or the reference controls. The last step is adding back the autofluorescence or the amount of light that was subtracted. When we use autofluorescence extraction, that click on the software, what we use is autofluorescence is not going to be subtracted. It's going to be considered one more fluorochrome in your panel. It's going to be treated as any reference control or single color control, and we will finally use it for unmixing. So let me show you two examples before we go deep into that high complex tissue. Just to point out how useful doing that click on the software is to get better resolution. And the simple scenarios are cell lines or populations that are not highly heterogeneous in autofluorescence. These are induced pluripotent stem cells that were transfected to express GFP. If we look at the forward scatter site scatter profile, it's a very tight population. It's granular. It's emitting a lot of light, but it's one single subset. And when we look at the signature, let's look at the top one. You see emission out of the UV, violet, blue. We all, in this particular case, we see yellow, green, red. Remember, on the y-axis is the intensity of the signal. But an observation just from non-transfected cells is that if I care about GFP because the peak of emission is going to be blue 1, there is going to be a lot of light in the non-transfected, that's going to be my baseline, my background. So if I go now to the ones that I express in GFP, that background is going to affect my ability to see what's positive, especially considering in this case that the GFP expression is low. So if I click and mix, using those multiple options, right, default and mixing, and the unmixing with extraction. So if we look at the non-transfected, this is without extraction. So what I'm seeing is these are the negatives, right? No GFP present there, and it's occupying almost half of the plot. So less space to know what's positive and a lot of background. So if I go and look at the sample after click or not clicking on the extraction, just default and mixing, I'm seeing the negatives and the positive very close to each other. We could still gate, but it's not a clear gating, and it can be subjected based on the observer. But if I do autofluorescence extraction, all this light from the unstained sample is going to be extracted. Now that's going to be my 0. And positives could be at the same intensity, but my ability to resolve these populations or my resolution, that separation, it's much, much better because the autofluorescence has been extracted. So easy case because there is only one population and one autofluorescence to be extracted. Another example, this is an 18-color panel. It's human PBMCs. And we see two subsets, right? Lymphocytes, monocytes. If I gate on lymphocytes, you now are familiar with the pattern. UV emission, violet, a little bit of blue in the early detectors. Critical here, what fluorochromes are in the panel. For example, we have brilliant violet 570. Brilliant violet 570, peak of emission is violet 8. So as we see here, there is already light there. That's going to be my negative, where my negatives will be. So depending on what marker I pair to that fluorochrome, I'll see better or more or less separation. So in this particular panel, once again, if I don't click on autofluorescence extraction, this is what I will see. The marker that was here on brilliant violet 570 is CD8. This is where the negatives are, 10 to the 4. And this is just coming from the autofluorescence, right? In this case, CD8 is highly expressed. It's easy to gate on it. But if you have a dimly expressed marker, that's going to be gone because of the autofluorescence. So the key point of extracting is, if I show you how it looks when I extract this, that autofluorescence is now the new fluorochrome. I'll be able to remove that light or extract that light. The negatives are now down to 0 because autofluorescence was removed. And the separation between what's negative for CD8 and positive for CD8 is much, much better. And again, that's critical for dimly expressed markers with with low frequency. And we see the same for CD4, same impact, similar impact when we look at memory subsets, CD45, R8, CCR7, the 4 expected compared to what you get when no extraction was done, because you get all the light from autofluorescence. So now let's look at the case study. The skeletal muscle model induce and why it's so critical. There's so many cell populations present there when an injury is induced. So if you induce injury in the muscle fiber, a lot of populations from the bloodstream are going to be recruited. They are highly important to induce the remodeling and of the tissue. And the critical part when we talk about autofluorescence is that they have different profiles. So they are not going to go up and down within that signature at the same place, different intensity. So that's a more complicated scenario. And I want to show you the results for that. Populations you can see there: neutrophils, eosinophils, monocytes, macrophages, and on top of that, different stages of maturation and differentiation in the macrophages. Lymphocytes, the fibroadipogenic progenitors, and stem cells, and multiple other populations. And you see that from microscopy. So this image is using just DAPI to understand where the nuclei are, and seeing with green field, what we get here is just the autofluorescence, get no exogenous dyes. And if we use red illumination, we also see, right, all the red dots that indicate that it's just autofluorescence, and definitely characterized as a highly autofluorescence tissue. So if I show you how the tissue, same sample, looks on the on an aurora or Cytec system, this is the scatter profile. You see it's a full occupying the full space, not clear definition of what it is, what. And we know because of the way this injury was induced, we were expecting to see a lot of immune cells infiltrating the tissue. If I show you the signature, we were seeing some examples like this. It is not a clean profile like we were seeing on the pluripotent stem cells or in the lymphocytes. It's all over the place in intensity, in the patterns. And if I focus again, once again, on one single detector, violet 7, low intensity, high intensity, so a lot of diversity in that sample that makes more complicated. So this is a panel that was used to characterize the sample, mainly targeting myeloid cells and multiple markers. The key point is, if you see that high autofluorescence, you want to select carefully your markers so it is not affecting the areas where you get the highest. It's not affecting the resolution. So you want to either avoid using those areas or using markers that are highly expressed like CD11B, and reserve the nice areas protected from autofluorescence for the key markers or markers with low expression in your population of interest. So it's a 14-color panel. Once again, these are skeletal muscles. What I want to show you now is what happens if you don't use full spectrum profiling. What happens if you don't use multiple autofluorescence extraction, which is the strategy you need in this case, given the diversity of populations. So if I don't use extraction or full spectrum profiling, let's say I just use compensation, and we have that option in the software just to use virtual filters. And here, gating at CD45, CD11B, because again, the bulk of the population we care about is myeloid cells. So if you want to look at the double positives, When we do that, we can clearly gate on both scenarios. This is compensation. This is using unmixing with multiple extractions. What we see, but one observation is that the negatives, right? They, and this in curbing population, we see better alignment when unmixing is done. Second observation, out of the myeloids, we care about neutrophils, and those are defined by the presence of Ly6G. If we see ability to see that population is affected by how much light the autofluorescence is giving you. If you're able to extract it, then the separation of your positives for Ly6E, your neutrophils, it's much clearer. If after that, out of the negatives, I want to define eosinophils by the Siglec F expression, similar, a lot of autofluorescence coming to that channel where you want to identify your particular market and better separation there. All the gating, as I'll show you later, was done by using FMOs. If out of the negatives, I want to now look at macrophages by the double positivity for MERTK and for CD64. So this is the area I care about. It looks very similar. So it doesn't really matter if I do extraction, compensation, and multiple autofluorescence extractions because these detectors or these fluorochromes are not highly impacted by autofluorescence. So the ability to see positivity is similar. But now if I go deeper on those macrophages, markers like A480 and all the 6 markers, he pointed that if we look at top versus the bottom, here you're seeing, you could define this as double positive for these 2 markers. But what we are really seeing is the autofluorescence coming into 785, into 570 especially. And once you extract, you realize that most of the events were negative. It was just a false positive, and that the positivity is better defined when you are able to extract autofluorescence. And this is another similar case. FITC is one of those channels, or the channel where you detect FITC, it's also receiving a lot of autofluorescence. So being able to extract allows you to see better what the true positivity for FITC is. So that's the final result, right? Where we were able to get better resolution by using extraction of multiple autofluorescence. So this is to explain you what's the workflow, how we get there. An important consideration is that you might not need this if you are using spleen, because it's less complex. You don't need this if using whole blood, probably, unless your granulocytes, it's a critical population, because eosinophils are going to have a very unique profile. Or if you're using just PBMCs. But if you're using solid tissues, that tends to be the scenario, tumors, where you will need this type of approaches. And so tissues with or samples with a high degree of heterogeneity is where you want to go for this workflow. And we call it the 4D workflow. First step, how many signatures you have. And we will go step by step, just to give you a general idea. 2, are they different? They might be just showing increased intensity, like lymphocytes, monocytes, but is really their spectrum, the ups and downs in the signature different? Then you need to put them in the experiment to be able to extract them. And for that, you need controls. And finally, you want to define out of the AF signatures that you selected, which ones are critical and really impacting the data. So I'm going to show you side by side what's happening if I tried the multiple options, right? The multiple options we have described so far, it's just default and mixing. I don't do any extraction. The autofluorescence is going to be added back. The other option is default and mixing with extraction that click on the software. And the last option that we will discuss, the 4D workflow, it's not clicking on that checkbox, but defining multiple signatures in your unstained sample. Similar gating, 45, 11B, double positives. We care about the macrophages. And then we want to see 2 markers, MHC class 2, Ly6E. And let's see how it looks, right? Here, things look very packed on a portion, but you could still gate. The negatives are really high, right? 10 to the 4, at least for 6E. If we look at the extraction, it looks better separated, but we see this bleving of the negative. That's an issue with the data. But if I do the 4D, now the negatives are beautifully around 0, nice symmetry, and a clear separation of the populations that if you have an FMO, you will be able to define what's positive or not. And an important consideration is that if you have these two markers, at least 11 be there, just to get out populations that are not of your interest, because you care about, let's say, lymphocytes, B cells, T cells, then you might not need the whole workflow, because those cells don't have high autofluorescence, then won't be impacted as much. So if we look at the same markers, especially looking at MHC class 2, that would be relevant for those. No matter if you do extraction or if you don't do it, or if you do multiple extractions, your ability to see MHC class 2 is the same, right? Because lymphocytes are not highly autofluorescent, and their autofluorescence, then that's not going to affect resolution. So depending on your markers, the panels, the populations of interest, you might not need to go deep as we will do. How long do I have? Just making sure. Thank you, sir. Thank you so much. Because we will go step by step. First thing, right? Look at your unstain. See the signals, see the different detectors. We explore the signature to look which detectors show you more variability. So if I show you, for example, blue 3, violet 8, this is unstained. There is a lot of variation. Some cells have very low emission on those detectors. Some of them mainly on B8, some of them on both. So that variability is clear indication that you need to explore further. How you would do it? Different approaches. What we prefer to do now is to oversample all the events. You characterize all the events in the sample, create multiple gates, understand the heterogeneity in the sample, creating signatures, so defining multiple signatures in that sample. So let's say out of that particular tissue or unstained sample, we define 12 total. So that's the first step, how many you have in there. And if we look briefly, AF1, AF2, they actually look similar, right? And how they go up and down, where detectors we get the emission. AF4, AF5 also look similar, very characteristic of macrophages, that yellow, green, and red emission, something we don't see here. So now the next step is how different they are. So within the software, we have a metric that is called similarity index that allows you to understand how similar or how unique two populations are in terms of their signature, and mainly in terms of their emission more than the intensity. That index, that metric, goes from 0 to 1. 1 indicates high similarity or populations that are the same. So we define uniqueness, but anything below 0.98. So what you can do on the software is rank all those signatures that were identified from AF1 to AF12. Because now we will be able to tell, for example, that AF1, as we were seeing just visually inspecting the plots, it's similar to AF2, similar to AF3, and similar given by the fact that we got 1 for the similarity index. What we can clearly see is that, and this is color-coded, so AF11, it's very different from other signatures, very clear. So that we first oversample, because we want to understand all the events that are in there, and then we downsample, identifying which ones are unique based on the similarity index. So this, out of those 12 signatures, we define that 5 of them have those similarity index numbers below 0.98 or equal to 0.98, as we see in here. We will use them as the new tags, new fluorochromes present in the sample to get better resolution. And let me show you how they look. If we also look at the scatter profile, they have very unique patterns, right? Low scatter, more side scatter, and very different from each other. So it's supporting the idea that they are very unique. And if we look at the signatures, the same. And if we actually pay attention to AF11, we see low emission, but high out of R1. Very unique, very unexpected, but important also to see how low that emission is. So that when I ask you to take a look at the signatures, it's not that easy to visually see what are the differences. So the best way to do it is by overlaying them and by excluding brightness from the equation, right? Just normalizing the data, where 1 is the highest detector where you get the emission or the highest emission. And if I normalize 5 of them, what I clearly tell is blue looks different, black looks different, and that's AF1, AF11. All the others look kind of similar with some differences that were defined by the similarity index. If I now look at the intensity of fluorescence, how much light we're getting, the one that was very different, AF11, it's very dim. So even though it's different, it might not be contributing that much light or background on your negatives that affect your resolution. But the one that is going to be more critical is AF4 now. All this light will be the negatives. It's around 10 to the 5th. So very difficult if that's the population you want to characterize with your markers and the fluors in the panel. And if I now show you more of a log scale, definitely, this is where the negatives are going to be for these different populations. So important that we have a way to extract it. And as we see, they are very unique, so we need to extract separately. Because if you extract that much light from this population, you're going to get negative numbers. So you might want to be careful defining them and understanding how critical. What we do next? We try different options, right? We have the default without unmixing, the unmixing with extraction, just a click on the software. And this new option, which is unmixing with the workflow, the 4D workflow. In that workflow, as I was saying, we add fluorochromes to the panel. So you have all your fluors plus the 5 fluorochromes. You don't click here because it's just extra fluors in the panel. And we added a total of 5 because those were very unique. So let's look at the data. This is general gating, where we gate on CD45, single cells, cells that are alive. We remove antibody aggregates. We care about the 11B positives. We have a lineage negative to remove other subsets, T cells, NKs, B cells. We gate on neutrophils using 6G. I showed you this before, Siglec-F. This is the final gating strategy with the best and mixing results. We define macrophages, and then we check macrophages there. We also care about DCs, so defined by 11C and some markers out of those DCs. And we also care about monocytes, defined out of negativity for all the markers and positivity for this markers. So that's the final result. Beautiful resolution for every single subset, which is what we care, no matter the panel, no matter the sample. How we got there and how we know it worked, comparing what happens if you don't do it. And so for that, I'm going to go population by population and showing you the FMO data and how different things can be, how things can be different depending on the strategy you use. For neutrophils, we care about the expression of Ly6G, and for eosinophils, the expression of Siglec. That's nice. That's the gold standard, what we expect, being able to see them separated from the negatives. Let me show you here comparing FMOs to define gating, multicolor, and the 3 strategies: without extraction, with extraction, and with multiple extractions, and the critical marker like 6G. What we are seeing here is if I don't do extraction, autofluorescence is going to take all the space that you have to define positive, so I can barely see where they are. If I do extraction, but only one with the whole sample, what we are seeing is, yeah, I still can detect the populations. But the only observation is you see this blebbing. Most of these events are negative, are below 0. That's unexpected. You shouldn't have that. The negatives should have symmetry around 0. So if I go and extract multiple ones, I get that most of them around 0 and the separation. So that would be the improvement there on neutrophils by using multiple extractions. If I now focus on eosinophils, FMO, multicolor, and the 3 strategies. I'm going to focus your attention on this population for the eosinophil definition out of Siglec-F. Difficult. Autofluorescence is there. If I extract autofluorescence, but not for every single subset or in a specific way, I see it, but definitely much, much better separated if I'm able to extract the autofluorescence for eosinophils for that population by using that multiple signatures that we define. Let me show you another marker and things that don't look that pretty. CD64 out of 3 subsets, and CD64 versus different markers on the y-axis. We see here, for example, the population curving up. This is just autofluorescence as we see here. So the issue with not extracting, that you will be identifying as double positive so many events. The issue with not extracting all of them, that your population looks negative because it's overcorrected by having an average autofluorescence that doesn't represent that population, and how things look much better. What you need is it's perfect alignment between negatives and positives on both axes, that orthogonal distribution. And you don't get it if you don't extract autofluorescence in a specific way, thinking that you have multiple subsets. So if I now move quickly into macrophages and see what are the benefits of having the strategies and how different the bad data is going to look if we don't do it. These diagonals, those indicate there is something wrong, especially if it's out of the negative, something wrong with autofluorescence. You have something else in there that was not extracted properly, and how better it can look when you add those multiple tags. If I now look at macrophages and the CD169, looks good after extraction. It looks really bad if you don't extract it, but the extraction you see is tilting to the left, and that's better corrected once you do multiple populations. Once again, here, if you don't extract, you won't be able to see what's real Ly6E. You will be able to see it, but with distorted populations in the negative, in the positive 11C as well, and a better definition of negatives and positives and double positives when multiple extractions are used. Let me skip this one in macro. Oh, it's also important because being able to extract autofluorescence, this is macrophages, and again, FMO's multicolor. If I use the FMO without extracting, this is all what I will define as positive. So I'm going to be missing part of the population, and again, autofluorescence. And the fact, an important critical point here is that if I do that, and then I define monocytes out of the negativity for MER-TK, then there's going to be contamination with macrophages. And I'm going to overestimate populations like we see here. Now, sub-definition of monocytes based on these two markers. So it's affecting your population, your ability to quantify it. It's affecting the populations that you're going to quantify in the sequential gating if you need the negatives or definition of negatives. So that's step number 3. How the different strategies look, which one looks better in terms of resolution. The final one, it's every fluorochrome you add into a panel is going to add spread into the data. So we are adding 5 more fluorochromes, 5 more autofluorescent tags, and that's going to introduce spread. Your negatives are going to be wider, and things are you might end up losing resolution. So the 4th step, it's how critical every of those signatures. Try and mixing with only 4 and mixing with only 3, to see how things look. And just quickly, if we remove autofluorescence 11, that one that was really low, that was not really adding much light. So it's different, but not impactful. And I show you the data for all of them versus only having 4 extracted. The data looks similar, but what we are seeing is the spread of this population looks higher compared to this one. This is all of them versus only 4. So it's not really having an impact. You still can see it. So eliminating it, you don't really need to use AF11 since it's not really changing the data, thinking what's the population it's affected. We can do the same idea, removing maybe AF9. When I remove AF9, I start seeing autofluorescence here. So compared to what we are seeing on top, and I start seeing these diagonals out of the negatives that it's something wrong with autofluorescence. So multiple strategies, iterative removal of those autofluorescence to get the better resolution. So we have seen how this 4D workflow helps to improve population resolution, allows you to extract multiple autofluorescence profiles. And once again, it's critical not in every single workflow or every single sample. It's going to depend. What we do, it's 4 steps. Discover, where we capture all the signatures to avoid missing anyone that could be impactful. Then we distinguish them, making sure we understand which ones are unique by using separation index. Then we add them into the workflow, into your experiment as new fluorochromes in the panel. And finally, determine last step, which is fine-tune and mixing. Check how the populations look, use your FMOs, see how you're gating, your definition of positives, it's changing. Important that it's not always needed. if you have a very simple assay, you don't need this complex exploration of the AND stain. That you need good panel design considering how the AND stain looks. And we are working on having this automated. So it's going to be easier to do these explorations in highly complex tissues. Recommendations, if you're using a spectral system and if you want to characterize autofluorescence, bring enough events. Ideally, the first time, as many events as you have in your multicolor samples, so you have a well representation of the different subsets you will get in your pooley stain. If you have multiple tissues, multiple treatments, day 1, day 2, drug 1, drug 2, bring multiple AND stain controls. I told you how different autofluorescence can be depending on how you treat the cells, how much light you get, how much granularity, and the impact of that in how much light you get. There is a feature on the software where you can create specific controls, and those controls will be extracted separately. Let's say you have spleen versus blood, that's going to be extracted independently. Explore your signature, see where you can have your fluorochromes because there's too high or too low emission and your resolution will be compromised, and try to design the panel. And definitely we help a lot. I mean, the application team support is helping a lot on understanding those samples and help you characterize them. That's all on my end. Thank you so much to the team at Cytec, fantastic group that we've been working on autofluorescence for a while, and the samples for this study that were provided from University at Pompeu Fabra in Barcelona. Well, thank you so much, and I'll be happy to take any questions.
Thank you, Deanna. That was a wonderful talk. I have a question. This goes a little bit more. As long as you're extracting them as fluorochromes or as fluorescences, do you actually utilize them in any way? Like, I mean, through either granule development or showing some kind of development through, characterize them in some way where the macrophages are developing so they change in autofluorescent, characteristics, or T cells are changing slightly in their maturity. Can you utilize the autofluorescence channels you create as their own channels and analyze that in a grouping plot, right? Or whenever you're.
Yeah. So the good thing with if you look at a pseudocolor plot and display the parameters, you will be able to see this AF1, AF2, AF3, and be able to kind of distinguish them. The other thing that I didn't mention is ideally we should be able to understand what AF1, AF2, AF3 were using lineage markers. So one of the approaches we've been trying is, depending on the signature, identify what's the detector where you get the less autofluorescence and use it to, let's say, define F480 and understand that particular signature corresponds to alveolar macrophages, red macrophages, and understand from the markers what population you were dealing with, and then design panel based on that and understand better. Because here it's blind, the extraction. We know there are different things in there. We don't know what they are. We kind of know based on the markers in the panel, but it's difficult now having the multicolor scenario. But single staining with markers, using fluorochromes that are far from that autofluorescence emission has been great to understand what they are. And something that I would recommend too.
Okay, we have a couple other questions. Can you talk, you mentioned that the 4D workflow is going to be automated soon. Can you share any details about that?
We're working on it. Highly, believe me, I'm working on it.
Well, there's interest. Here's a question from online. Can you comment on how extracting the multiple autofluorescence and it's back. Can you comment how extracting the multiple autofluorescence signatures can vary between samples and how this can impact when you're doing unsupervised data analysis?
That's a very difficult one, right? Especially thinking about longitudinal studies and how much variation you get across samples, and you're seeing that across treatments. best piece of advice would be, depending on your experimental system, not only the sample type, but all the treatment conditions, staining conditions as well. Bring as many controls as possible, and ideally, before the study starts, characterize multiple ones. Like what we used to do at the course was 10 samples, and just from normal donor, and understand what's the variation, and definitely bring an unstain every single time, because you won't be able to reuse unstains. As we are seeing that things in autofluorescence changes so much, even in T cells, if you use FOXP3 perm buffer, if you don't use it. So it's not only the cell, it's how you treat it. So have an unstain that matches. I know that's difficult, right? If you have a tumor sample, you might not have enough cells to do the multicolor and to have the unstain, but that would be the only way to know how the autofluorescence looks and be able to extract it correctly. So bring singles or unstained cells every single time would be critical, unless you test multiple samples and you define that they all behave the same. I doubt it, but that would be validation of part of the protocol.
Okay, I have it.
Lina, you had a question?
I have a question, if you don't mind. Are you going to recommend for labs then to kind of start building their own autofluorescence library? So with essentials, with studies, to kind of have a idea of what autofluorescence could look like for certain samples, to kind of build, like not as a definitive, but giving the users an idea. When I'm working with monocytes, I can expect this level of autofluorescence. And in this condition, I can see that the autofluorescence shifts here, and kind of building that at least database so that there's an idea for users to look in certain directions when they're starting this out. Because I imagine as a new user, like going, oh gosh, like how do I separate that first plot where we saw it just looked like everything was there? It would be very difficult to kind of devolve that on your own, being new, if you were new to the field and new to spectral. So how would you recommend for somebody that was new to start that process?
Yeah, good point, Robin. The library for learning purposes, yes, not for analysis purposes, but yeah, I think it's important. We have seen common things, complicated by the staining protocol that could be different across sites, but macrophages from red pulp in mice, from spleen, they look very similar, no matter what experiment was on, what staining protocol was used or stimulation was used. They have this characteristic yellow, green, and red emission. So I'm definitely think that it would be useful for everyone to know how they look and build that library. Eosinophils with all the flavins that they produce, yellow, green, gets really high, no matter the sample. So that's definitely useful. And all the solid tissues, but for example, with this one, we use liverase to get the cells out of the tissue. And but that changes depending on the treatment you use, the enzyme you use. So the library would be useful if it's well defined, what was done with the cells, how they were treated, but definitely critical so people understand. Also from panel design, right, to know which fluorochromes I can use for that particular tissue, and depending on the marker and the marker expression. So yeah, that's going to be useful. More questions, Dina?
Yes. If you are using cells for the unmixing, so the autofluorescence from that single color control, how would that that also be?
That's a very good point, Dina. Yeah, because just a quick case I was working on, and yesterday someone mentioned the smart tubes, and I've seen how smart tubes or storing the samples in smart tubes changes autofluorescence in a particular pattern in some cells. So you get that kind of contaminating signal in your single color control. Recommendations, beads, or a surrogate tissue. But it requires a lot of optimization. When I try initially cleaning knowing where you get the highest, but it's a tricky one. And yeah, it's critical because you're gonna have all that extra light coming just from some events, contaminating the single color and affecting and mixing not only from the extraction of autofluorescence, but on defining the different fluorochromes in the panel. Beads is what we have seen with the caveats using beads, but that's what I would recommend, or a tissue that doesn't have the problems with autofluorescence that can help you define negatives and positives. I know, difficult to have. Beads is what I would try. No? Thank you so much.
Right. Thank you very much. All right, I think we're adjourning for lunch. No. What are we doing? Okay. Let's adjourn for lunch. Okay. All right. Trying to get the schedule rebalanced. That's where a little bit of the confusion is coming from. All right.
So adjourning for lunch, and we're going to meet back here in an hour for Jared's presentation.